Okay, let's unpack this. Today, we're taking a deep dive into some really critical medical distinctions. Specifically, we're looking at how spontaneous abortions are classified and managed. Our source material is this incredibly clear excerpt: Spontaneous Abortion, Classification and Management. It's got this very precise table.
Right. And
It starts with something called a threatened abortion.
Mhm.
So what does that actually signify? Why is that label so important, especially early on?
Well, it's crucial because it pushes back against that assumption. For
Yeah.
threatened, yes, there's bleeding, maybe some cramping too.
Okay.
But critically, and this is the key part, an ultrasound confirms there's a live fetus. And importantly, the cervix is closed.
A closed cervix, got it.
So the management is typically careful watch and wait. And what's really fascinating, or perhaps reassuring, is that less than 5% of these cases actually end in abortion.
Wow, less than 5%.
Yeah, so getting that early, accurate assessment, it's transformative. It shifts things from, potential tragedy to cautious optimism. It saves patients enormous distress and stops unnecessary interventions if the pregnancy is actually viable.
We're talking about inevitable and incomplete types now.
Right.
What's the critical difference there, and how does the approach change?
So connecting this to the bigger picture, both inevitable and incomplete still involve bleeding and cramping. But the absolute critical differentiator is the cervix is now open.
Open cervix, that's the turning point.
Exactly. For inevitable, the process is clearly underway. The fetus might be low in the uterus, maybe the membranes have ruptured. It's, inevitable.
And incomplete.
For incomplete, the really crucial insight is that there's residual tissue left behind in the uterus, even if some tissue has already passed.
Oh, okay. Residual tissue.
And that's not just a small detail. That residual tissue is a major clinical issue it needs addressing to prevent infection or, prolonged bleeding.
So what are the options then for both?
The management strategies are quite similar for both inevitable and incomplete. Watch and wait is one option. Or medical management, often using misoprostol, the source, gives a specific regimen, 800 micrograms vaginally now, then again 24 hours later.
Right.
Or a minor surgical procedure, a DNC, that's dilation and curettage.
Right. We've covered scenarios with active symptoms, bleeding, cramping, but let's talk about complete and missed types. How do those work?
Okay, so what the source highlights about complete spontaneous abortion is actually quite relieving in a way. There's no management needed because the uterus is empty, the cervix is closed up again after everything, the sac, the placental tissue is completely passed. It's resolved naturally.
So complete means actually complete, nothing more needed.
Exactly. Now, contrast that starkly with missed abortion. This is often a silent loss, which can be really hard emotionally because there's no bleeding at all, typically.
No bleeding. How is it identified then?
It involves fetal death in utero, which is confirmed when an ultrasound US shows no fetal heart rate.
Wow.
But the fetus and sac are still inside.
I see. And the management for missed.
It's similar in options to inevitable or incomplete. So watch and wait is possible. Or medication, the source mentions a combination, actually. Mifepristone first, then misoprostol 24 hours later. Or, again, a DNC.
Okay. And just briefly, the source also mentions two other types, recurrent and septic. Sounds like these flag further important issues.
They definitely do. Recurrent is pretty straightforward in definition. It just means 3 or more consecutive spontaneous abortions.
Right, which would trigger more investigation.
Exactly. It prompts a much deeper look for underlying causes. Could be mechanical issues, genetic factors, environmental risks, that sort of thing.
And septic. That sounds serious.
It is. Very serious, though thankfully very rare. It's a severe complication where the uterine contents get infected. You'd see symptoms like foul discharge, maybe a fever.
And the response has to be immediate.
Absolutely. It requires immediate IV broad-spectrum antibiotics, followed quickly by emptying the uterus, usually with a DNC, though sometimes misoprostol might be used. It's a true medical emergency.
Wow. Okay. So pulling all this together then.